I'd just like to ask Gustav about the MR arthrography study he showed. I think it's very difficult in that if you have, did you have one surgeon assessing the labrum? I know certainly, I mean, I've got enough work to do, and and I don't want to sound as though I'm banging on defending radiology, but I think it's, I mean, certainly, if you look at ultrasound of the shoulder, most studies show that ultrasound is 90% accurate, and that sounds fantastic. And then I think, well, hold on, that means for every 10 tears, I'm missing one, which doesn't sound very good, and my surgeon would let me know if I was. So I think even, as you say, 80 to 90% in a specialized setting might not be good enough. But I think you have to remember that I think a number of studies in the past have been detrimental to radiology because the gold standard has been one surgeon. And one surgeon's assessment of that area can be, I mean, who's checking that for reliability? And also, in some studies, they're not blinded, and I think that some surgeons would, if they've put the patient through surgery, they usually find something abnormal. And you showed in your labral assessment that there's quite a wide variation in labral assessment, and that you had slight irregularity and things like that as an assessment, as a positive finding. And some people would argue, well, is that really a positive finding? So I just think that needs to be put in context, that I don't think MR arthrography is the perfect technique. I think the hip is really difficult because you've curved articular surfaces. You have granulation tissue, just as we have in the meniscus in the knee. So if fluid can't go into a defect, we can't see it. So if there's a defect there that happens to have a little bit of granulation tissue over it and fluid won't go into it, we'll not see it. So I don't think MR arthrography is perfect, but also I'm not sure that all assessments of the joint are perfect, as it has been shown in meniscal studies in the knee.
Yeah, I totally agree with you that you really should look at the setting where the study is performed, and this is a third referral center, so this is a highly selected population. But on the moment, if you look at which patients would get surgery for possible labral pathology, that are the subjects who have a lot of clinical symptoms. And what this study showed is that the MR arthrography is not that bad. No, it's quite reasonable. But the population is so selected that it doesn't change your it doesn't change your outcome after MR if you would operate for a labral tear or not. And that's that was one surgeon. Of course, that's a limitation, a limited generalizability. But if we look at the other studies, and there are quite a lot, they actually all show the same pattern, that the population is there's so big chance to have a labral tear already that a negative MR will not change the chance of having a tear in that population.
I think you're completely right in that specialized situation. I think the other problem we have, again, not with your study, but in general, is that if we do meta-analysis of radiology, radiology is changing so much. So if we take shoulders as an example, if you look at the ultrasound studies from the end of the 90s, early 2000s, the technology we have now for assessing ultrasound assessment of tendons is completely different, and making a similar assessment with MRI from 2000, MR arthrography studies in 2001 are not the same as MR arthrography studies today in terms of magnets, software and coils. We have a much better resolution. So again, I think that's something to bear in mind when you're doing comparison of longitudinal studies, and as technologies can change completely, and is still changing.
Yeah. Last thing I would like to say about that, in this highly selected population, with almost everybody have a labral tear, then you almost need a 100% sensitivity to be of use. So if in future it's already worth to know if there's a labral tear, if you think it's only 50% chance that he has a labral tear, then it's a very useful investigation. So I think we should more look at the population in this case than think that the MR arthrography is a bad diagnostic instrument, because that's not the case. Yeah.
Thank you
Yeah.
for your comments.
One question.
Rintjaj Griegra from the Netherlands. My question is about labral tears, which touches upon almost all presentations this morning. So you may decide who wants to answer my question. You pointed all out the importance of the labrum and the association with pain. But in the more properly designed studies, also including asymptomatic patients, we see only weak associations between a labral tear and pain and other complaints, which is mainly because labral tears are highly prevalent in asymptomatic population as well. So is anybody of you aware of characteristics or other things of the labrum which can distinguish between those who will become symptomatic and those who will stay asymptomatic?
Thanks for the question. I agree that I'm not pointing to my own presentation, but many of those patients had labral tears and other things that were more likely to cause the pathology. So whenever you intervene on a labral injury, you want to know how the outcome was, whether or not the repair or whatever was done, in fact, improved the patient's symptoms. That's the ultimate test. In terms of characteristics morphologically, I think we're not there yet. You know, you're exactly right in that it's hard to get normal volunteers to submit to an MR arthrogram. You know, it's an injection in the joint. The IRB has problems with that, and I don't blame subjects for not wanting to volunteer. So we have a poor evaluation of arthrographic normals. We have a good idea of what normal MR looks like without arthrograms in patients. But as we've seen, those sorts of studies are insensitive to labral pathology. Now, I agree with Phil yesterday when he commented that 3T may in fact change that, but it hasn't changed it yet. There are no papers that compare 1.5T arthrography with 3T non-arthrographic studies and show that in a good study that it's more sense specific. So I think that the time will tell. But what we'll look for is other things related to the labral tear. We'll look for delamination of a cartilage. We'll look for bone marrow edema, but those are more conval things. That is hyaline cartilage, not fibrocartilage. We'll look for a perilabral cyst, but does that mean that it's symptomatic? Usually not. So the answer is we can't really say which of them are symptomatic, which aren't. Just like we have problems in the knee with meniscal tears. Again, we'll look for bone marrow edema that's related to it. That's helpful, but not very prevalent. I don't know if anyone else.
Yeah, I just wanted to add to that. I think the thing is you're focusing on one thing, one structure. We don't know what the pain generator is, just like the spine, the knee, and the 70-year-old osteoarthritic knee. What is the pain generator? It's probably not the degenerative tear. In the shoulder and handball players, a lot of them do have labral pathology, but it's non-symptomatic, and I think the hip is the same thing. So to focus on one structure is wrong. You know, for me, I think the intra-articular lido might help out, but there's a lot of structures intra-articularly that can be the pain generators. Which one is it? Nobody really knows. So when you say in asymptomatic patients, how old were they? My guess is somebody above 40, most of them will start having labral tears, just like in the shoulder. Most have undersurface fraying of the superior labrum at a certain age. It's very common. In the knee, you're going to have degenerative tears of the menisci. They've just gotten accustomed to living with it, you know. But probably in a younger pathology, it's going to be more acute and symptomatic. That's just my thoughts on that.
I think as we've gone a bit over time, we're going to have to leave the remainder of the discussion to the lunch break or to the coffee break now, unfortunately. We'll start up maybe 10:35. Yeah, 10:35. Meet up everyone here, and then we'll continue from there with the workshops.